Good afternoon, everyone. My name's Gareth Livingston. I'm here to talk about flattening-free radiotherapy that we got as an innovation, I guess, in Port Macquarie. And a slight disclaimer is this has very little to do with patient-reported outcomes. So I apologise if I digress from the theme of the session. But for the non-rad-onc people, I'll do my best to explain very quickly what the flattening filter is and does. This is a diagrammatic view of the machines we use to treat our patients. We get X-rays by bombarding this little target you can see up the top with high-energy electrons, and that produces a stream of photons that have a higher intensity around the central axis as opposed to the periphery of the beam. So if you want to deliver a homogeneous dose to a target in a patient, this can be problematic. So what conventional radiotherapy does is it has this little steel filter which actually flattens out that beam, which you can see at the bottom, and it just makes the planning side of things a lot easier. So FFF, as simple as it sounds, is the removal of this to treat patients, and the benefit of that is the dose rate of what we're doing is much, much higher on the account of the fact that the beam no longer has to travel through this steel. So I think it's a relatively new technology, and there's only a few centres I'm aware of in Australia that has it, so we are very lucky at Port Macquarie. The main difference between the two beams is the difference in the dose profile of the beam. What you're looking at here is the flattened beam profile for different field sizes and the corresponding FFF beam underneath. And you can see that for very large field sizes, the output drops off quite markedly for FFF beams comparatively with their central axis. So potentially treating larger targets with FFF might be disadvantageous, but this problem gets less and less with smaller field sizes, so much so that for very small field sizes, the difference is almost negligible. So just quickly on flattened beams, a few observations. Very rarely are our patients flat or what we're trying to treat flat. We more and more use complex beam arrangements or dominant weighted fields, which basically means that the dose distribution in the patient is not flat as well and needs modulation. So this all flows on to the fact that we now more and more treat with IMRT and inversely planned treatment techniques. I would estimate that at our centre we would treat 85-90% of our cases with IMRT or VMAT. So this questions the very need for a flattened beam in the first place, and potentially having a more efficient treatment delivery is a good trade-off. But essentially FFF has come about as a way of treating stereotactic and ablative treatments more efficiently, which are characterised by very high doses, non-uniform doses to very small targets. So FFF is perfect for that. Going through a bit of physicsy stuff that I'll skip. These are some published benefits. The one that we're really after, obviously, is that very high dose rate. These are the dose rates that we get on our machine as opposed to the published ones. So there's a significant increase there, and perfect for things like SABR, which can take 15-20 minutes, an hour, maybe more to treat. So just quickly, what is SABR? This is a slide that I have pinched off someone that I think sums it up nicely. In conventional radiotherapy, we aim to get a nice homogeneous dose across the target, and we do this by giving field sizes and margins that account for penumbra, where we actually lose all that with ablative treatments, and the way we cover the target is by delivering a lot more dose into the target itself. So that's where the ablation comes from, and that's where the very long treatment times come from. So having a flattened beam really doesn't provide any benefits, and having a slower output is disadvantageous as well. I'll skip through these next slides. I was going to talk about the work that our physics department had done, gathering beam data, modelling it in the TPS. I'll skip through it. We did have the ACDS Audit team come to our department and actually audit our beam models to make sure that they were good, and they gave us the seal of approval. But suffice to say, a lot of work, a lot of time, a lot of energy and a lot of money has gone into what could be construed as chasing a little bit of efficiency for a small group of patients. But so why is there this need for speed on these patients? Well, we would consider there to be a quality add in all of this as well. For SABR, even though we use rigid stabilisation equipment and we use 4D image alignment processes, the patient still moves during the course of treatment. The mean target position still can drift over the course of treatment, and how much that moves highly correlates with how quickly the treatment lasts or how long the patient is on the bed. So this is some published data just on intrafraction motion for SABR, and even though they look like very small moves, we don't really have any margins to work with. So any kind of displacement during the course of treatment is, we don't want it. So we've got options for dealing with this, and the ones that I can think of is you can accept those risks if you want. I don't presume anyone would do that. You might increase your margins. I suppose doctors probably wouldn't want to do that as well, considering the doses we're talking about. You can do more imaging, which is what I presume departments do. Certainly we used to implement mid-treatment imaging routinely on all the patients. That allows you to correct for those displacements, but it's got the disadvantage of actually making your treatments longer again because it's adding a new process in. So the last alternative you're left with is to do faster treatments to begin with, minimizing the chance of this motion, and actually, if you're confident enough, you can reduce some of your imaging as well. So another context to all this is, I guess, what maybe would have been a few select patients a few years ago is actually becoming more and more of a commonplace treatment. Certainly surgery is still the number one choice of treatment for early stage non-small cell, but I would have thought most centres around the country probably offer SABR for patients not fit for surgery. And more there's research being done looking at SABR and surgery for patients who are fit for surgery, and a potential outcome of that may be that we might start seeing patients start opting for radiotherapy over surgery, potentially. And another thing to consider is the amount of oligo metastatic cases we might be seeing in the very near future, and that's not just in lungs as well, but these do often present as multiple lesions as well, which go to emphasise the time issue. So this is a case study. This was the first patient we used FFF on, and I liked it because it highlights an issue with SABR in that while we know SABR works very well for single lesions, we know far less about how many courses of SABR are safe, how many courses of SABR following conventional radiotherapy are safe, what are the cumulative OAR doses are safe as well. But this is a lady who initially presented for a thyroid condition, and in subsequent scanning detected a left upper lobe lesion, and in subsequent investigations for that found a mirroring lesion in the other lung of similar size. So she was eventually diagnosed with synchronous primary adenocarcinoma lung tumour, and the surgeon referred her for radiotherapy, and it was found SABR was going to be her best chance of a good outcome. So this is a bit of literature that we rely on quite heavily, looking at these issues. It's from the Mayo Clinic in Rochester, US. It deals with 63 cases, which represent a growing proportion of their SABR load. And these cases had up to 4 courses of SABR. And by and large, they tolerated the treatment very well with minimal toxicity. So this became a baseline article for us in some sense. So this is the plan we came up with. This is a FFF VMAT plan. I guess every centre might have their own way of planning this. You might grapple with a single isocentric technique, which might make the whole thing a bit quicker, but the issue you're going to run into there is with baseline shifts between the two targets, it's nigh impossible to correct for both of those targets and align for them, I would think, even with a hexapod couch. So we routinely do these separate treatments, which have the impact of making the treatments longer, but we feel making them far more accurate as well. And the other thing we did is we actually reduced our TDs for this patient to accommodate for lower OAR doses as well, so that's a trade-off. So just in comparing our plan towards that article, suffice to say that the doses we came up with were a lot less than presented in that the literature I just showed you. But so we were very confident she would handle the treatment well, and I believe we're past 6 months follow-up, and she's had no significant side effects to report, which is good. We obviously toyed around with a lot of different plans for this patient as well. There were subtle differences in the dosimetry. The big thing we wanted to see was how quickly these would deliver. We have a high energy FFF, which was significantly quicker than the conventional methods. We actually chose the 6 MV FFF on reasons of better calculation of lung dosimetry. So we went with the 6 FFF, and you're only looking at 2, maybe 3 minutes per treatment there. That is a lower TD. We had a similar patient finish treatment with us last week, and we were able to save about 9-10 minutes in actual treatment time. And to put that in perspective, that's probably about how long it takes us to treat a prostate case. This is probably getting away from FFF a little bit, but just goes to show the overall kind of journey we've made. This is probably about 12 months ago. Our patient had static beam IMRT, and the treatments for this one were actually getting quite lengthy. I would say individually this would take probably about an hour for us at the time, and combined probably well over an hour. And a large portion of that time is the imaging that takes place. We're strong proponents of 4D imaging, NCCI. This was a video file that was meant to play. It was too big to send through email, so you'll just have to bear with the screenshot. But a 4D image for us probably takes about 90 seconds to acquire. The whole process of registration, correction, and prepping for the next field probably takes about 5 minutes, and we might repeat this 2 or 3, maybe even 4 times per case. So this adds up in the overall scheme of things and is quite time consuming. So if you can reduce your treatment time enough to feel confident that you don't need to do as much imaging, that's an added benefit of all of this as well. So just in summarising all of that, we've made a big effort to try and make our SABR deliveries as efficient as possible, and FFF has played a part in that. Obviously there's a quality add to that as well, but a little added benefit is we've routinely dropped the mid-treatment imaging for our SABR cases, so that's further increased the time gain that we've got. But I do feel compelled to say that whilst the IGR process is the longest part of our SABR process, I don't think I'm wrong in saying that it's probably the highest priority for us in treating these cases and critical to safe SABR delivery. So that's all I have. Thank you very much for your time.